or what we deploy is actually behavior change and lifestyle recommendations, and not pharmacotherapy. We are actually a community center to the South Asian population, not only here, but now nationwide. And we have also, we're doing some pilot studies within India. So this is what actually the South Asian Heart Center is and has done over the last 13 years. Thank you.
All right, I just want to thank both the speakers so much. I think that it's been wonderful to hear about, the science that's emerging, as well as sort of this grassroots community-based program that really evolved from the patient stories that inspired you, and how that outreach is sort of feeding into lifestyle change, and now how it can be enhanced further, I think, with the very specific South Asian focused data that's coming out of the group. So I want to be mindful of time. I think if people have to leave at 6:30, that's fine, but hopefully we can open it up to questions for the speakers, as well as comments, things you might have been thinking about that are inspiring you to make change in your work.
I have a question for Dr. Kanaya. This MESA calculator, that there's kind of two flavors of it. One that looks at the spectrum with the ranges, with greater than 100 and greater than 400. But then there's also an age-adjusted kind of calculator where you look at coronary calcification from the age perspective and look at where you stand with it. Which one do you, number one, recommend? And number two, are the calculators going to change with the South Asian data?
That's what we're hoping. That's our long-term goal, is to create risk prediction models for South Asians that predict risk better than what the MESA. A paper that just came out of Stanford, actually, led by Fatima Rodriguez, looked at the PANTS data, looked at Sutter and disaggregated by ethnic groups, and they looked at the pooled ASCVD risk equations. And just like what you found in the Kaiser data, you published that study showing that the pooled cohort risk overestimates risk of cardiovascular disease events. In the Sutter data for South Asians, it overestimates risk. It overestimates risk in any race ethnic group. So these calculators are not very well calibrated to populations. They came out of research studies with older data, like from the 80s, 90s, 2000s. So we need to kind of look at this in a new light. And the risk factors that have always gone into these models are just clinically available, easy. So we're hoping to make an optimal model using the richness of our data, and then make a clinical model to see what can approximate that, what can be done in the clinic setting.
See, there is a MESA calculator, so when I read my CAP score, so for age, MESA is actually done a good job of. You go online, it tells you like if your score is 55, so for 40-year-old, 95th percentile. So for the patient especially.
Well, you use
the
that.
same thing I think can be done for South Asians too, when there's enough.
So
and you approximate with Caucasian.
Right, so based on
South
our
Asian.
data, the white and the South Asian are tracked very
Very
well. I
close.
showed you the baseline
Yeah.
data of CAC adjusted for the kitchen sink, they track completely well. So use the white data calculator for MESA.
We do that.
Which
And actually the commentary that it spits out is very easily explained to people. So then they totally understand and get it.
In the absence of a better
That's
calculator.
I'll just point out that I was Fatima's mentor on that paper that Alka mentioned just now, that none of the risk prediction tools are perfect by any means. The best receiver operating characteristic, even there, was 0.74. And if you just put in age, it's 0.7. And flipping a coin is 0.5. And I think this is something that is going to be important as a grassroots community organization to communicate to patients, right? The limitations of risk prediction, that despite whatever the MESA calculator spits out, we're wrong like over 20% of the time. So
Well, actually comes up to another point, and that is, it is easier for us to say when you're off, but it's almost impossible to say that you're okay. And people go to doctors' offices to find out if they're okay, and we're giving them information saying you're okay because your numbers are okay. But in fact, we don't really understand why people get coronary arteries.
Absolutely, and that should be communicated, that there is a lot unknown about that, and I'm mentoring Fatima on her K award now to use machine learning and other prediction algorithms to bin people a little bit better, and perhaps have one model tuned more for sensitivity and another model tuned more for specificity, with, you know, cut points on where you might use one model over the other. So I think that's an important gap in what we communicate to our patients.
You had a question?
Okay.
Sorry.
Well, I think that one of the things that we should be ready to move into is new dimensions. Because, just to mention one, our group has finally been able to identify a molecule we can measure in blood that tells us how well people efflux cholesterol from lesions. That's a very important component of this, which has never been accessible before. And because what we're finding is there's a subpopulation of people who may have lipoproteins that look good, no inflammation markers, they can't get cholesterol out of the artery. And so I think we've got to think in terms of expanded dimensions. And I think another one that's going to be huge is that of the intestinal biome. Because I think we're talking about diet and heart disease, we know there's something there. But, you know, there are about 1,500 organisms that can inhabit the human intestine. Most of us have about 700 or 800 of those, and we may share half of them, but not all with everybody. And it may very well turn out that when you eat certain foods, you're actually called, I'm almost certain that when you eat certain foods, you are shifting the intestinal biome representation. And this has got to be important biologically, because now we know that microRNA of microbial origin is circulating in human blood. And so it's telling our cells, and particularly there are proteins and peptides which we absorb from our intestinal biome that tell us when to eat and activate appetite and so on. But I think it probably goes much farther than that. And just to illustrate this, I know of 3 subjects who, when they eat certain legumes, develop fasciculation. Okay. And when they stop eating those legumes, the fasciculation goes away. So we're being dictated to, I think, by intestinal bacteria. And I think probably what we eat has more than just the content of saturated fat or cholesterol or something. I think we're getting feedback from those organisms that activate insulin resistance or, you know, very important parameters like that. So I would recommend that perhaps, you know, all of us who are looking at patients should be talking to people who can collaborate in studying the intestinal biome, because I think we're going to find some very definitive determinations.
I want to second that, John, and I want to thank you. You may not remember, but when I was a resident, I rotated through your clinic, so I want to thank you for.
Well, you
for
were that very outstanding resident. How could I forget?
20 plus years later, but I wonder if you might be able to comment, because I was very impressed with you and your colleagues' work on HDL. And one thing that I have noticed in my epidemiologic studies is low HDL is quite prevalent in South Asian populations. However, the Mendelian randomization studies haven't worked out when we look at what genes cause low HDL and do those same genes cause heart disease. And the CETP inhibitors, which raise HDL, that did raise HDL, but unfortunately did not work in terms of reducing cardiovascular outcomes. If you might be able to comment, because we haven't obviously shown that it's causal, the low HDL, but I did see it in the Sutter data. Half of South Asians had low HDL, but it was only 20% of the non-Hispanic whites, and they were the group, along with Filipinos, that stood out in terms of being more likely to have the low good cholesterol.
Some thoughts about this. One, the whole question of low HDL has been confused for years because high triglycerides cause low HDL, and people have never corrected for that. And we've actually published this. There's a set of curves called isoplats that actually give you, that we published, to give you that relationship. The reason for this, you might want to know, that we visualized is we know that the cores of triglyceride-rich lipoproteins are highly disordered and lots of entropy. And we know that the core of HDL particles, incidentally, we think there are about 25 molecular species of HDL in human plasma. So, you know, we've published 9 of them, but we've got a lot to do. And they turn out with other properties that you wouldn't expect necessarily, like binding endotoxins and so on. But the point is the core is full of cholesterol ester, which is tightly packed. And if you remember your high school chemistry, those particles that want to get into an environment of randomness so that the entropy increases. And it turns out there's a protein, this is really fun to look at this, there's a protein called cholesterol ester transfer protein that transfers the cholesterol esters from HDL to this random disordered place they want to be in. It's a tube. The stuff simply diffuses through that tube. And there's some triglyceride comes back. But basically, it's going from one area of entropy to a vastly different one. And that's why this is true. If you correct all those numbers for the isoplasts that we've published, you find that a lot of this discordance between low HDL and other things vanishes. So I just, you know, for anyone who's doing any statistical analysis, correct the HDL levels for the isopleth value, and then it's going to straighten out very much of the inconsistency. So anyhow, I think that it's obvious that we have to start thinking about multiple speciation of HDL, all these different things, but just to illustrate, we found a mutation that's associated with low HDL. And that same mutation was associated with high cancer risk. So we're looking at a lot of biology here. And I think we should include as many of these factors as we can. The genomics is very important, but the intestinal biome is going to be very important. So this is going to expand.
Is there a neurologist in the room? Can you talk about the relationship between HDL and dementia, if any?
She's the
Yeah.
neurologist.
Yeah, is there a neurologist in the room?
Okay.
Albuquerque.
Well, no, I don't know anything about it.
I'll say from my perspective, you know, we think very much of so many components of dementia and vascular cognitive impairment as a vascular disease, right? And so the more micro infarcts a person is having or silent cerebrovascular disease having, the more we're starting to see that track with loss in memory and cognitive function. So I don't know about direct, you know, relationships,
Well, how
but
about the
certainly
transport of
indirect.
amyloid? How about the transport of amyloid?
Well, I'll have to say, first thing, that amyloid precursor protein is converted to amyloid beta, you know, and recently it's been demonstrated that amyloid beta is transferred at the blood-brain barrier to circulating lipoproteins, and it's carried largely by very low density lipoproteins. This is a new idea. And so, yeah, we sort of know that the apolipoprotein E isoforms are very important. There's ApoE2, 3, and 4, and then some less common variants that one finds, particularly in African Americans. But anyway, we know that E4, which differs by one amino acid. If you have one E4 allele, you have about 5 times increased risk of having dementia. And if you have 2 alleles, it's about 20-fold. This is telling us that circulating lipoproteins and lipoproteins in the brain have a very important dependence upon this isoform. And so we're, in our laboratory, working very hard on looking actually at the lipoproteins in the brain. And we're hoping to come back in a year or so and tell you what we found. But I think that the transport of amyloid beta is dependent upon lipoproteins, and it's influenced by ApoE4 isoform.
And ApoE is higher in some patients.
And I think it's really interesting
didn't know
from a
that.
clinical perspective that when we do these, and I don't know if you did this in Sala, but are there any cognitive outcomes that are being collected? I mean, obviously Mesa did that, and
We've been trying to get that. for 2 years. We're still trying.
We're in the wrong.
We haven't given up.
The wrong institute, probably.
No, because the institute.
Louisa, can I ask a quick question going back to low HDL? So actually so I have a couple of questions related to lipids. I'm so glad you're here, Dr. King. And I know Dr. Stockton, you and myself, we actually share some pretty high risk South Asian patients that I've sent over to your clinic. But just again, thinking from a high clinic volume standpoint where I do see a tremendous amount of South Asian, young, this is what's so scary is that they're young. And trying to think of anything more that I can do to really risk stratify, lower risk for potential acute MI. And one of the things I guess that I'm learning from today's data, from Dr. Kanaya's data, is that it was impressive to see that, yes, exercise was low. And then I guess what I'm learning also from our Cal State East Bay folks is that the diet seems to be very rich in the fats, the sugars, these types of things. So that would go with this lipid profile of high triglycerides, low HDL. And so I guess my question to you is this really still driven environmental, or is this, because part of what I struggle clinically wise is classifying as if it's a lifestyle modifiable factor that I can do versus maybe this underlying genetic that we still don't quite understand, that we're still really having to really kind of do more genomics or
Well, my impression here
these
is that we've got a lot more to learn.
Right, okay.
And we are collaborating now with an internationally famous lipidologist who does mass spec spectrometry studies of lipids. He studies 400 lipids. Okay. Now we've just stumbled, not we, but other people, have just stumbled on the fact that there's one lipid which is jumping to center stage. It's sphingosine 1-phosphate. You'll be hearing about it if you haven't. And it's telling cells what to do. And it's a very important signaling molecule. Well, when we look at the lipoproteins, we're finding cerebrosides and all these aldehydes and so on. What are they doing in biology? Well, I think some of them are probably inhibiting viruses, and other ones are, I don't know. But we've already found microbicidal activities in HDL and so on. So we have a lot of biology to learn. But that's why it's important, if studies are being done, that you retain plasmas, retain DNAs, because, the expansion that's occurred in this field, in our clinic, we've discovered 5 previously unknown diseases because somebody looked different, And Mary Malloy, who's the co-director of our clinic, recently discovered the man with no ApoE. There was a lot of conjecture about what would happen if you knocked out apolipoprotein E, and they decided not to try to have an antisense. And then she published this, I think, the latest paper was, I think, in Nature. And this guy is totally functional. The human brain does not need ApoE to function. There must be surrogate proteins that are carrying things there, but that's the kind of information we need, because I really want to know what ApoE4 does. And I can't tell you yet, but.
I think you were the one who taught me about total cholesterol to HDL ratio, and maybe following that as a measure in people.
Right, well, again, non-HDL for sure, but it's so impressive to see these HDLs down to 20, triglycerides.
Well, we're
just settling in the 600s, even with folks who are on like fish oil.
And that may increase the risk of cancer. So,
I'd like to put a question on the table based on our discussion in the steering committee previously, which is, if we really want to prevent these events, what screening program do we need to put in place? It's a very controversial issue where I think many people in this room believe that the heart CT scan is definitive and important, and yet it's not what the U.S. Preventative Task Force recommends broadly in the population. And so, what screening things, blood pressure, lipids, blood sugar, heart CT, and when, at what ages? And I'd like Dr. King to go first, please.
well, I think that all of those things have been connected to heart disease risk. But what I'm saying is that there are a lot more dimensions that we need to learn. And I'd like to just share my view of coronary disease. We for years have known about the atherogenic lipoproteins. We're learning more about it, LPAs jumping on center stage and so on. But intermediate density lipoproteins, which is called dysbeta lipoproteinemia, is a high risk. People with ApoE4 have more heart disease as well as dementia. We have to understand all that. But there's another whole dimension now, and that's people have been looking at plaques. And they're saying, oh my God, this is an inflammatory disease. That wasn't originally in the minds of people in this field. Because they've been finding cytokines, they've been finding inflammatory cells, they've been finding oxidative transformation of phospholipids, propagating this weakened plaque which ruptures and leads to an MI. And so now the CANTOS trial, which most of you probably are aware of, was carried out a couple of years ago and absolutely proved that this is an important part of atherogenesis. They gave an antibody, a monoclonal antibody, to an interleukin-1 beta, and they had 3,500 men, all had an MI. Half of them got what we do now, and the other half got the antibody in addition against this cytokine. 35% reduction in new coronary events. Wham! It says that we've got to be in the inflammation area. And so I'd offer a third area now, and that is that of efflux. Cells have the ability in the artery wall to kick out cholesterol. It's called efflux. It involves a couple of proteins that were discovered by colleagues of ours in Norway in large part. And but it turns out that people are different in this respect. Here's a whole new phase of coronary disease, which hasn't, we sort of knew it was there, but there was no way of getting at it until a few years ago in our laboratory we discovered the particle which accepts the efflux cholesterol. It's called pre-beta-1 HDL. We devised methods for very accurately measuring it, and it turns out that it defines a group of people who are at risk. The hazards ratio for C-reactive protein, where there's a lot made of this, is 1.24. The hazards ratio for pre-beta-1 HDL is 2.0. So we have a new dimension. I'd like to see all these new dimensions added to what we do, because we were missing the people who couldn't deflux. But that's a serious problem. If you can't get rid of the cholesterol, this will build plaques. And so now we can add those people.
How does that compare to the HDL efflux assays that are out there?
Well, the efflux assays are beautiful, but they're very difficult to do. You have to culture cells and do this and do that. But we can just measure the pre-beta-1 HDL.
But are they highly correlated? Because the question is, we've looked at HDL efflux in our cohort,
Yeah.
and it wasn't highly correlated.
Well,
with
there are a lot of
outcomes.
factors, So what we're looking at is the level of the acceptor particle. And the interesting thing is quite what is predictive, because the high levels are associated with risk. But I liken that to trucks lining up at the loading dock, and they're not receiving anything, so they pile up. So we have high levels. If you get the cholesterol onto pre-beta, it's rapidly converted to bigger particles of HDL.
I think the importance of efflux was perfectly shown in these studies where you had the CETP inhibitors. So the reason they didn't work is that they stopped efflux.
Yeah.
Right? You don't let the cholesterol migrate from the HDL to be evacuated from the body. So you're just building these huge HDLs that are highly dysfunctional.
Yeah.
This is a great conversation. We should continue it outside with wine and more snacks. Thank you everyone for coming.
How much alcohol should we have?
As much as you, apparently 5 beers or something.
Daily.